Welcome to The Blend, a new podcast brought to you by the Journal of the Dermatology Nurse Practitioners and Physician Assistants. The Blend takes a deep dive into the expanding role of integrative dermatology, an approach to skin health that blends conventional medical dermatology with complementary therapies to address symptoms and underlying disease factors. In this four-part episode, Dr. Sonal Choudhary, a dermatopathologist, dermatologist, and director of the Integrative Dermatology and Skincare Clinic at the University of Pittsburgh Medical Center, and Natalie Gardinier, MPAS PAC, a Dermatology Physician Assistant at the University of Pittsburgh Medical Center Dermatology, take a deep dive into integrative approaches to treating acne.
Hello, and thank you for joining us. I want to welcome once again our advanced practice providers, physician assistants, nurse practitioners, and physicians in dermatology or any other specialties who want to learn more about integrative dermatology. We hope we are able to provide some unique insight about what is up and coming in integrative dermatology, and today we'll be talking about acne. Today with me, I have one of my star PAs, Natalie Gardinier, who has not been on this podcast yet, and this is her first time. So I would like her to take it from here and introduce herself to everyone.
Hi, Dr. Choudhary. My name is Natalie Gardinier. I am a dermatology PA. I received my training at Chatham University in Pittsburgh, PA. I have a special interest in integrative and holistic approaches to skin health, and so I'm really excited to be here today. Honestly, this is a very full circle moment for me, Dr. Choudhary. I actually discovered the PA profession as a patient myself. I struggled with acne for years and years, so to be discussing acne today as our main topic is really exciting for me. It was frustrating at times for me to deal with this acne. In fact, I failed several rounds of conventional treatments and they didn't work for me. It was really, really isolating. And so eventually, the PA that I was seeing at UPMC Children's Dermatology actually encouraged me to start addressing some internal factors that might be at play. So we started to address gut health and nutrition. And that was when I really finally saw some improvement in my skin. So that experience was what really sparked a passion for me, not only to go into dermatology, but also to take on this more integrative way of looking at skin. And it taught me that, yes, conventional medicine is important, but it's not the whole story for every patient. So now as a PA, I really get to bring both worlds together and help my patients heal from the inside out. And I believe you have kind of a similar experience yourself.
Yeah, I mean, I have shared my acne story with almost every acne patient that I ever come across. But if you were to see Natalie's skin now, you won't believe what she just told you. It is perfect skin she has. And my skin also looks pretty good at this point, but growing up, it was not such, I didn't have what I have now. And I have gone through a lot of bad nodular cystic acne with a question of having whether or not I have polycystic ovarian syndrome. A lot of questions around that for a long period of time, actually. And I had to do isotretinoin 3 times over a period of almost a decade and a half. And even sometimes ongoing new factors can play a role in bringing my acne back. So yeah, it's very relatable when somebody says how much acne impacts them. It is not something that I can say, well, I have never experienced it. I don't know what you're saying. It is absolutely very close to home. And Natalie, thank you for sharing what you did, what you shared, and that makes your story, and what you're going to share further with us about the approaches, etc., that we will talk about today, even more validating. So I wanted to start out by introducing what is acne. We know that acne is a condition of the pilosebaceous unit, and it is very, very common. A very recent study, and I want to share the latest data for you from the Journal of American Academy of Dermatology, JAD, as we call it, and also sometimes we refer to as the Blue Journal. In 2024, they found that the overall acne prevalence was around 20.5% worldwide. And the highest prevalence among the age group of 16 to 24, this is the common age group that comes and sees us for acne, was about 28%. Another survey of about 1,000 adults in the United States, also who reported it themselves, self-reported prevalence, showed that in males and females between 20 to 29 years of age, there was about 43% and 51% respectively of acne. And this is what they, we're reporting what's on the skin, but the impact of this is much beyond that, right? Like we're talking mental health, how much it impacts a growing up person's self-esteem, definitely causes low self-esteem issues, depression, anxiety. And when patients ask, like, so why am I getting this acne? What causes it? Or what are the types of acne? Why am I having all these different things on my skin suddenly? Very technically speaking, the way we often read in our textbooks or describe it, there are few factors. The four main pathogenic factors I want to highlight is follicular hyperkeratinization, increase in sebum production by the sebaceous glands of the skin, increase in bacteria, especially often related to Corynebacterium, Cutibacterium acnes, C. acnes, also sometimes referred to as Propionibacterium acnes. Now, this is an anaerobic organism that often lives on our skin and can be normal to be found. But when somebody's suffering from acne, then it can really proliferate. And the last piece of it is inflammation. Which comes first? It's a chicken and egg situation. It is a multifactorial condition. So multiple things could be happening at the same time. So overall, just the four pillars of what causes acne is this. And then there's comedonal acne, and there's inflammatory acne, there's nodulocystic acne, or a combination of these.
Dr. Chaudhary, I would also like to highlight something that's important is the population of patients who we see who are affected. So historically, a lot of people think acne is just a teenage problem, right? And so we have patients really, we're treating across all age groups from adolescents, but also adults in their 30s, 40s, even beyond. And in fact, I don't know about you, Dr. C, but I think that the prevalence of adult acne is actually increasing, especially young adult women. They're coming in and they're like, listen, I don't really understand why this is still happening to me. I never had acne growing up, and now this is just really coming to fruition. And we think probably a lot of contributing factors, but one piece that definitely can't be ignored is the influence of our modern Western diet, which we'll certainly get into. But these high glycemic foods, lots of dairy products, processed ingredients, we know they all drive inflammation, hormone fluctuations, even changes in the gut microbiome. And so these all play a role in acne development. So when I'm treating my adult patients, I really like to highlight the fact that this is something that we need to address from the inside out. And that's where bringing together both conventional tactics and integrative strategies really makes a huge difference.
Absolutely does. And now that you brought that up, I'm going to ask you again. When you're seeing your acne patients, what are your few top things that you always include, or often, let's say, include in their regimen for most of your patients? So there's like maybe there's categories of things that you like to maintain throughout across all the regimens of your patient.
Yeah, so I like to keep things pretty simple. I tell them that there's this stepwise approach that we like to take with topicals, followed by oral medications. And then we have some refractory acne options like our isotretinoin that we have in reserve if need be. The nice thing about these integrative approaches, which we'll discuss, is that they can be incorporated really at any point throughout this regimen. So we'll come back to that. But I do want to start just with the foundation of topicals, specifically washes. So we talk about with our acne prone patients using some sort of salicylic acid wash, maybe benzoyl peroxide, and these are going to be keratinolytic. So we talked about how that follicular hyperkeratinization is one of the main pathogenic factors contributing to acne, and so targeting that with one of these washes is a really great option. We often do supplement this with more of a simple, gentle, maybe foaming wash for the patient, especially if they're not able to tolerate twice daily use of one of these salicylic acid or benzoyl peroxide washes. And then another option that I really like, kind of getting into the integrative approaches, is something called Neem wash. This is great for patients who want to take more of a natural approach to their skincare. So, neem is essentially an ingredient. It's derived from an evergreen tree. That tree is called Azadirachta indica. It is an herbal skincare ingredient. So, it has really wonderful antimicrobial, anti-inflammatory properties, and therefore we can use it to kind of fight the bacteria on the skin and prevent recurrence of acne lesions. And this wash has actually been clinically studied. There was a 2021 open label, single center, single arm trial that was done for 4 weeks. And they found the safety and efficacy of this neem face wash to be pretty significant. About 3/4 of the patients who either had acne or predisposed to acne had a significant reduction in the appearance of both inflammatory and non-inflammatory acne lesions. So not just those red inflamed bumps, but also those open and closed comedones. They also had a statistically significant decrease in the level of sebum on their skin and an increase in overall skin hydration. And then after the washes, we talk with patients about the option for topical antibiotics we can use to spot treat single inflammatory lesions or even use as a field treatment when they have more diffuse acne. And these are usually options that we incorporate in the morning for those more active lesions.
Yeah, Natalie, those are definitely the common things that I also have in my regimen for patients. Just to like kind of double click on this piece that you said about which wash to use for which patient. You can start out right with like, depending on what kind of acne they're presenting with. If it's a lot of comedonal acne, salicylate can be great, BPO can be great. If they have very sensitive skin, then those simple, gentle face washes can be great. A lot of pustular acne, Neem wash can really be a good addition. And since you mentioned antibiotics towards the end of your what you were saying, how do you think these topical antibiotics compare? Like, can you share some data on that with our listeners?
Yeah, I'd be happy to. So the two that we most commonly use are going to be your clindamycin and erythromycin topically. In fact, there was an older head-to-head study that compared the two. It's from 1984, but still strong evidence that really kind of set the foundation for how we approach topical antibiotics in acne today. And it compared the efficacy and safety of a topical erythromycin solution, it was 1.5%, and then a 1% clindamycin phosphate solution. And essentially, what they found is that they were very similar in terms of efficacy. After about 12 weeks of treatment, the treatment groups had a reduction in inflammatory lesions that was about 62% in the erythromycin group and 59% in the clindamycin group. And then non inflammatory lesions were also reduced by 43% in the erythromycin and 39% in the clindamycin group. So, pretty similar results. And then I would also like to note that there have been many, many studies out there kind of comparing monotherapy, so just clindamycin or erythromycin alone, compared to combination therapy, perhaps combination with retinoids or antimicrobials like a benzoyl peroxide. And these have really demonstrated significant improvement in treatment efficacy when we use combination therapy as compared to monotherapy alone. I would like to highlight that use of benzoyl peroxide in addition to the topical clindamycin. Specifically, we've actually had some studies that have shown that the addition of benzoyl peroxide really helps to prevent antibiotic resistance in patients who are using topical clindamycin on a daily basis. So I like to highlight for my patients, even if you're not able to tolerate benzoyl peroxide on a daily basis as a wash or a cream, try to just incorporate it once or twice a week, and that'll help to really improve the efficacy of your topical antibiotics over time.
Yeah, I mean, I love benzoyl peroxide. I use it quite regularly, even though my towels have turned all bleached up. But I have not given up on it. I use it for many purposes for myself and also for patients. But there's been a lot of conversations and data coming out about the benzene and benzoyl peroxide. We'll dive into that in one of our later episodes. I will take it to the next one, which will be topical retinoids or, tretinoin, very commonly used in acne regimen. And my personal approach to this also is using it in the evening. It's not a morning time usage cream often. It has to be used in the evening, but in the morning, one should use a sunscreen. That's how you can really protect all the benefits you are getting from tretinoin or a retinoid that is being at nighttime. There are, different generations that have gone by making retinoids. The older generation ones are retinoic acid, tretinoin. They do have those side effects of irritation, dryness, peeling, especially when you start. So people get enthusiastic when I sometimes refer to this cream as like a miracle cream. So I've started now calling it the teacher cream. And that helps to explain that literally tretinoins will work at the level of every keratinocyte, making changes through their DNA and reteaching the cell how to divide at a proper pace. That does not happen overnight. So getting enthusiastic and using a large amount of it, I sometimes find even a pea size amount is quite big. So I go with a quarter of a pea size. And starting low and slow is key with tretinoin. You want to let that adjustment of your skin happen. So you're not running into side effects like a lot of irritation, leading to redness and inflammation, leading to hyperpigmentation. So always going low and slow with tretinoins, any kind of tretinoins. The newer generation ones are adapalene, right? Adapalene is now over the counter, tazarotene, and then britarotene that is not as commonly available, but these are definitely more stable formulations. They have more shelf stability and less prone to oxidation. Also, they are less irritating to the skin. So adapalene is known to be a gentler tretinoin, and for especially those who react very strongly to the older tretinoins, going with adapalene can be a good option. Although it's a gel form, and I find people that's, the patients that will say, I love adapalene, and then a group will say, I don't. I personally have had difficulty tolerating gels on my skin because gel vehicles are drying in nature. So again, it's a trial and error to some extent, but at least having something like adapalene available over the counter definitely increases its accessibility as an option, right? And the latest one I want to add is adapinoids. These are the newest generations of tretinoin. Adapinoids are also known as oleal adapalonate, or OA in short. And these are novel third generation over-the-counter retinoids, which are precursors of adapalene. The data for this is in a 12-week double-blind randomized controlled trial, randomized controlled trial OA, 0.5%, which is that oleal adapalonate. It was found to be superior to the retinol 0.5%. Now, 0.5% retinol is sort of an in-between percentage. It's not the lowest percentage. We're talking a moderate percentage. And they found that OA was superior to the retinol 0.5% in improving skin aging findings like wrinkle severity, but also improved pigment intensity. And there was only very mild adverse events that were seen at follow-up visits, showing that OA was actually better tolerated overall than retinols as well.
So, Dr. Chaudhary, sometimes we'll have patients who say that they certainly cannot tolerate any of these retinoids. They're not willing to incorporate them into their regimen. What do you suggest for these patients?
Besides taking just very low and slow, there are maybe a couple of other things that one can do. Make it even lower and slower, I guess. One is to really reduce the amount by diluting it in a moisturizer. Since these are drying and irritating, keeping that skin barrier with some support using a good moisturizer, even a lotion-based, preferably moisturizer, that adds hydration while diluting this retinoin while the skin is getting used to the product. The second is something that I don't know if this is an actual phrase, but we often refer to as the short contact therapy. Okay. So at the end of the day, on the dirty skin, I mean, I'm not saying that it's like, you're playing in mud or dirty skin, but like say you have makeup on, or, you were out there and you were planning to wash your skin and clean your skin. Don't do that yet. First, apply your tiny amount of tretinoin on that skin. And even after 20 minutes or 30 minutes, then go ahead and wash that off. So you don't have to stay with that tretinoin on your skin or retinoid on the skin for long periods of time. You just wash it off and use the short contact as an option.
That's great. I think while we're on the topic of things that are gentle for the skin, I would really like to touch on clascoterone. So this is an option as a topical cream. It's an androgen receptor inhibitor. So it's counteracting the effects of DHT on the skin, which in turn can help to kind of decrease inflammation, particularly at the follicular level. And the associated sebaceous gland can have some reduced inflammation as well. So think of this as like essentially your topical version of spironolactone. It was really developed as a topical cream and solution for the treatment of androgen dependent skin diseases. So, not just acne, but also like androgenetic alopecia. Clascoterone was really the first of its kind recently approved. So, 2020 was when it was approved by the FDA. And really, it's just a one fingertip amount, so about a gram, and you're applying this twice daily to the affected areas. And sometimes what we'll do for patients, because this is not always covered under insurance, so cost can be a barrier, is we'll actually get compounded spironolactone, and we will incorporate this with maybe a niacinamide, for example, if patients really want to target some redness. And then we send this over to a compounding pharmacy. So the patients are paying out of pocket, but sometimes it's a little bit more affordable this way. And like I said, it can allow you to really tailor these topicals to target patient specific concerns for redness, or maybe they want a brightening agent. You can compound with azelaic acid. So we have a lot of options for these patients.
Yeah, and I think maybe one or two of our patients may have said that they noticed how this topical spironolactone, maybe not so much the very compounded versions of them, but just the spironolactone can have a very malodor to it. I know of someone, a friend who tried to use topical spironolactone for hair loss, and they just could not continue that because it smelled so bad. It was very repulsive. So, but yeah, but the combinations are such a good bang for your buck. I try not to give people just the spironolactone. If they have a need for, redness reduction or something like that, just like you said, I would combine it with something and make their regimen maybe a little bit simpler. So trying to use that for the best bang for their buck. You mentioned about combinations. Can you tell us why BPO, benzoyl peroxide, should not be used with tretinoin? And this is something to always, pay attention to, that when you're combining things, to not combine these two.
Yeah, so really important from a patient education standpoint. Benzoyl peroxide traditionally we know interacts with tretinoin, potentially reducing its effectiveness. We think through oxidation, degradation of that tretinoin. The nice thing is there's a newer generation encapsulated benzoyl peroxide on the market now. So it's a 5% microencapsulated benzoyl peroxide cream, recently approved about a year ago, April 2024. And it's essentially encapsulated in these little tiny silica microcapsules, which allows the drug to be slowly released onto the skin surface during application. It makes it more stable so it can be combined with other products. And it also helps to kind of prolong the therapeutic effect of the medication on the skin. So as a result, this is much better tolerated than your traditional benzoyl peroxide that you're getting over the counter, less irritation. And then while we're on the topic of compounding these topicals, I would like to just touch on a couple of other positives. Number one thing, again, we talked about how you can tailor these different concentrations for specific patients. And a lot of recommendations we have for compounding, we do these often in our clinic to simplify a patient's regimen, is to compound like an antibiotic with a retinoid, maybe glycolic acid or benzoyl peroxide. There have been a couple combinations that have really been shown to be particularly useful in their efficacy and safety, as well as feasibility for our patients. So we find that they really like a combination of like a retinoic acid with clindamycin, maybe tretinoin with clindamycin or erythromycin, glycolic acid combined with clinda, and then even benzoyl peroxide now with a clindamycin as well.
Yeah, that is good to know that we have at least a version now available of BPO for people with very sensitive skin, or to kind of, avoid that interaction of tretinoin, because most people have both of those things in their regimen. So the encapsulated version is a great option. The other thing that one should, probably not combine is azelaic acid with antibiotics, topical antibiotics. And it's a similar reason that it causes just chemical instability. And since we have been discussing tretinoin, I want to bring up an integrative option here, bakuchiol. It's really gotten some traction and popularity recently, because, it is another of those naturally occurring things that people often prefer. Its origin is in a meroterpene phenol, which is actually abundant in seed and leaves of a plant called Sorelia corylo. I don't think I can say this, but I think it's corylofolia. Sorelia corylofolia. Say that 3 times fast. And the data on that I want to share is that in 2014, there was a study done where bakuchiol was found that it is not really structurally similar to retinol, but functionally it is. And its effect on gene expression and biochemical processes is very similar to what retinoin will have, or retinol will have on the fibroblasts. Also, some case studies that came up, they saw that the twice-a-day facial application of bakuchiol actually had significant impact on aging of the skin, so wrinkles, pigmentation, elasticity, firmness, reducing overall photo damage, and also, without any retinol therapy associated side effects, which is such a big issue with tretinoin. Here we are trying to talk about all ways to reduce the irritation from tretinoin. So bakuchiol brings that to the table. And I also want to give you one more clinical study with this because I have it right here. Monotherapy. And this cream had monotherapy, the component used was UP256. This is actually a newly patented topical product, and it has 0.5% bakuchiol. This was studied specifically for acne. So they saw that inflammatory lesions improved, and also improved the post-inflammatory hyperpigmentation when using this product of bakuchiol.
Yeah, Dr. Chaudhary, I love bakuchiol, especially in my pregnant patients where I feel like I'm kind of at a loss for what to do. I think traditionally we think of clindamycin, azelaic acid as the products that are safe for pregnancy, but bakuchiol is also safe. And so this is an option for patients who are maybe getting worsening of acne during pregnancy, or even just want some help from an anti-aging standpoint while they're pregnant because they are pretty limited. So this is a great option.
We hope you enjoyed part 1 of our 4-part episode on integrative approaches to treating acne. Thank you for listening to The Blend. We'll see you back next time.